Um, so this is the 9th Journal Club meeting. To get points, scan the QR code. So the purpose of Journal Club is to introduce you to published literature, give you exposure to learning how to read these research articles in a low stress environment that you'll see if you work in any laboratories. It's to provide a space for you for practicing presenting any research that you may have and exposing you to different areas of academia. So basically our expectations that you generally just read the article before, try to come with your own ideas and question anything. If you have any questions about the article, discuss what it could be used for. It's a good practice of reading the literature and then identify the common structures of research papers. So the article we're going to be talking about this meeting is Patterns of Cardiac Troponin I concentrations as risk predictors of cardiovascular disease and death. So I chose a relatively simple idea for this one, just as an intro. So basically troponin is a complex of regulatory proteins. There's troponin C, I, and T. And they're used in muscle contraction and skeletal and cardiac muscles. Troponin I and T normally stay in the cell, but when they're damaged, they may leak into your blood, which is the idea behind this research. And troponin I, which you'll see as CNI or CTNI in the presentation, is unique to heart muscles only. So subclinical myocardial injury is going to be defined as low-grade elevations of the troponin I within normal limits, but those slow elevations over time. So development of cardiovascular disease is chronic and multifactorial. So it's hard to predict because there's environmental, genetics, and a bunch of different components that go into it. The cardiac concentrations of the cardiac troponin I slowly increase in the years preceding cardiovascular death. That's been shown through previous research, but there's limited evidence documenting such trends for non-fatal cardiovascular events, which is basically one of the reasons for writing this paper. So the hypothesis of this paper, is they created a large cohort of community dwellers and using several assessments of the cardiac troponin I over a time span of 25 years, they aim to describe the temporal trends in cardiac troponin I concentrations prior to the development of a cardiovascular morbidity and death. So this was actually a very interesting design. So they used one of the largest population cohorts that's used for medical research. They analyzed the cardiac troponin I with high sensitivity assays in 3,272 participants. And then they assessed the trajectories of that concentrations in the years prior to cardiovascular events. And they did adjust for age, sex, risk factors, and other comorbidities. So the Hunt study, the one I was previously describing, is the largest population-based cohort in Norway. And so Hunt 2, 3, and 4, that basically just describes the different time range that they take those samples. And so as you can see, there are many more participants in each of those groups, but not all of them were measured for that troponin level. But in Hunt 2, 3,198 participants were measured, 2,661 were measured in Hunt 3, and then 2,587 participants were measured at both 2 and 3. And then all participants measured were also measured at Hunt 4. So their statistical method using this assessed the trajectories of the concentrations from each study using a generalized linear mixed model with subject-specific random intercept and slope. And they defined the subclinical myocardial injury as concentration of the cardiac troponin I above sex-specific cutoffs. So that was 4 nanograms per liter for women and 6 nanograms per milliliter or per liter for men. They performed all assays for the cardiac troponin I as a continuous variable transformed by a log2 logarithm graph and according to the previous cutoffs. All regression models were adjusted for age, sex, history of cardiovascular disease, as well as prior selected variables influencing cardiovascular risk. So the results in table 1 of the paper, the baseline characteristics at Hunt 4, according to the hospital admission for heart failure and other cardiovascular mortality. So the most common admittance was older men with diabetes and cardiovascular disease. They had higher C-reactive protein, impaired renal function, and higher cardiac troponin I concentrations at all visits. Additionally, patients admitted or died from heart failure had the steepest incline of cardiac troponin I compared to all other events, which included heart failure, stroke, and other non-fatal events. So the yearly average was 0.235 nanograms per liter increase, while the average for no events was negative 0.022 nanograms per liter. So we can see the trend there of the slow increase leading up to events. The steepest increase was found in patients with heart failure hospitalizations, then stroke, and then myocardial infarction. So, and then additionally, the atrial fibrillation trajectory was comparable to no events. The trajectory of the cardiac troponin I was the steepest for cardiovascular mortality, which was twice as steep as the non-cardiovascular mortality. So the 0.28 nanograms per liter for that mortality, and then 0.145 for the non-cardiovascular mortality. So the conclusions of this study for fatal and non-fatal cardiovascular events are preceded by slowly increasing concentrations of cardiac troponin independent of established cardiovascular risk factors. So there are several limitations of this study, some identified in the study itself and others also included. So they had a general lack of accurate diagnostics. Majority of it was self-reported patient history. While they did measure the troponin levels, they weren't super they didn't necessarily test for myocardial events. There's also a healthy user bias. So basically all of these patients are not regularly, but seeing a doctor every couple of years. And they're proactive about their health. So that may lean towards people that wouldn't have been in the study if they don't go to the doctor. Additionally, in the paper, it stated that the finding may be less applicable on an individual basis. So it's looking at it from, hi.
Hi. Do you have by chance how it passed?
That it's online, but it ends at 12:20.
Okay, thank you.
Yep. So like I was saying, the findings may be less applicable. So there was a trend looking at the group as a whole, but it may be not necessarily as useful for individual basis. There's also a missing analysis of other biomarkers, such as peptides that are also characteristic of myocardial infarction. The major one that stood out to me was it was a very homogenized population. It all took place in a relatively small area in Norway. So it's gonna be mostly applicable to European Caucasian people. Additionally, those people may be more likely to live a certain lifestyle rather than other countries. If you had any that you noticed, you can share, or any strengths of the study that you noticed.
I think the thing that stood out to me the most when I was looking at it is just that it wasn't like you kind of touched on it, but it just wasn't super specific. Like if there was a genetic factor, like what the treatment was like following each cardiac event. If like I feel like they should have done like all patients who suffered a stroke and took blank as a medication going forward to really see, because that tied into access to healthcare, access to doctors, like we were talking about, and kind of also like the ethics of each doctor and like kind of how they decided to go about treatment like holistically, or if they took a certain medication. So I think that's what stood out to me the most about it. And I just wanted to clarify, so the Hunt study, is that just like referring to the population in Norway, like that group, or is it more so like a company?
So it's basically they take like one of those group of people would visit the doctor in that range, and then if they chose, they would like allow their information to be seen and added to the study. So it's just it was through the Norwegian like public health thing. So yeah, so it was done through their government, but it was conducted as a study of just tracking people for that long-term longitudinal study.
And so after they found that like following a cardiac event, they had increased levels of troponin, like did they suggest a solution for that, or are they just stating the fact?
Can you repeat that one more time?
Yeah, so like with research, like this research study, did they go further to present a solution of any sort, or are they just kind of trying to show that troponin levels would increase after the cardiac event?
So they did offer, we'll get to, I think it's the next slide maybe, about they didn't necessarily like say like ways of like lowering troponin or anything like that. It was more of they were looking at this characteristic seen before events, but they do offer ways of different risk factors that are correlated with the troponin increase on ways to like help with cardiovascular health. So right before we switch to the applications, what were the strengths of the study? What was good about it?
I think I liked like the large population, because even though it was a specified location, at least they would have a better idea and like more well-rounded. Um, I like how they did the male versus female and kind of did the baseline and the troponin levels following the events as well. Um, yeah, I think it just could have been a little bit more specific.
Yep.
That was amazing.
Okay, good. Yep, so the clinical outlook or the impact. So using this, health professionals could potentially look at patients and their cardiac troponin levels, and do more regular testing of that and see if they can use that to prevent or see when those cardiac cells are in distress or leaking that troponin. They can described in the paper, it was things that improve cardiovascular health that are correlated with things that are have a connection to that troponin level, such as lipid lowering medication, the moderate physical activity, weight loss, and then other pharmacological interventions. So basically anything that helps relieve that distress on the heart, to prevent the troponin from leaking out, which is an indication of heart disease. So for future studies, it would be useful for a serial assessment of the cardiac troponin to identify patients appropriate for risk factor directed preventative measures. That's potential study was talked about in the paper. One I suggested is you could repeat the study looking at troponin T. It may be less accurate because troponin T is found in skeletal muscle cells. But you could also look at that. What other studies would do you have anything to offer for that?
Offer for troponin T.
Or like any studies, like future studies that we could use to like further investigate this correlation?
Yeah, I think troponin was a good like choice, obviously, because it shows damage to the heart cells, the cardiac cells, but maybe we like specify it with treatment plans, just because I feel like troponin does show that the cardiac cells are in distress, but following a cardiac event, like it would make sense that they're still in distress. So if anything, I think it should be more of an evaluation of treatment plans following a specific cardiac event, as opposed to just being like, are there higher levels of troponin? Like kind of like what treatments are most beneficial to decrease the troponin levels, which would then decrease the risk of heart disease, you know?
Yeah.
So
Yeah,
maybe more of like a treatment, like based around which treatments are most successful for what types of cardiac events, measuring troponin.
Yeah, so looking at what interventions could decrease that troponin concentration and therefore decrease cardiovascular events. Another one would just be doing it in a different population group, just to see if it can be translated across different populations.
Right, like environmental factors and stuff.
Yeah. Did you have any other questions about this paper? Any comments?
No, I don't think so. It was a good presentation.
Thank
I
you.
feel like it's
Yeah.
so this was like last semester too, right?
Yeah.
Journal Club 9. Okay, got it.
I'm gonna stop the recording real quick.